سڵاو قوتابیانی خۆشەویست ئەو کاتتان باش بابەتی ئەوڕۆمانە سەر سپاینە کە دەکات محاضرەی پێنجەم سپاین کۆندیشن بە خۆتان زانن لە کۆندیشن هەرە کۆمەنەکانی musculoskeletal injury یا musculoskeletal problem. The most common symptoms in the spine is it's pain. We have to first ask about the history. Pain, character pain, sharp pain, dull pain, or location of the pain, whether it is in the back or is there any radiation to the lower limbs, relationship to exercise or activity, whether it's increased by exercise or activity or not. Is there anything that removes the pain, like special position? Also, you have to ask about neurological symptoms like numbness, pins and needles, weakness. Past history, is this pain is for the first time or the patient has previous history of spinal problems or any other orthopedic problems? Family history of spinal problem is also important. So what we get from the history, from the pain, if the pain is insidious and persistent, worse in the morning, the cause of the pain may be medical, like, for example, ankylosing spondylitis. But if the pain is intermittent and associated with activity, the cause of the pain may be mechanical, like disc prolapse. Disc herniations and nerve impingements radiate to the lower leg or foot. So the patient has radiation of pain to the lower limb, you should think about disc herniation. If the patient tells you he has night pain, you have to think about the tumor. If the pain can be removed by aspirin, you have to think about osteoid osteoma. So the characters and the history of the pain is very important. If there's a family history, you ask about if you have this condition in your family, it might gives you information about disc disease, ankylosing spondylitis, Reiter syndromes, and other spondyloarthropathies. عندك شتمان هي red flag في spine زور گرینگه اگر اوانی هبو یک لوشتانی هبو they require consideration of pathology that might be life-threatening or require surgical intervention. So please, if the patient has a spinal problem, you have to make sure the patient has not one of these things. Like the patient's age, if it is less than 10 years of age, that's a red flag. If the pain is first episode and over 60 years of age, this is a red flag. Unexplained weight loss, chronic cough, night pain, menstrual bleeding, intermenstrual bleeding, altered bowel functions, altered bladder control, visual disturbances, and bilateral weakness of the lower extremities. اگر نخوشك back pain وزائدة مو مواصفات هيبو أو red flag وتحالات خطر بيشتين با urgent consultation urgent might require urgent surgical interventions or according treatment, but should be urgent intervention. On examination, you have to look up, examination starts with the inspection. So it comes out, from the behind, you have to check for the levels of the shoulder. Both shoulders should be at the same level. If there's scoliosis, one side might be lower than the other side, okay? Or you have to look at the hair tufts over the spine. Again, you turn the patient to the other side. You are looking from side now. Check for increased kyphosis or decreased lordosis. Note below, scoliosis may be due to lateral muscle spasm or nerve root irritations. The second thing is move palpation. You have to palpate the spinous process, sacroiliac joints, facet joints for tenderness and muscle spasm. The third part is movements. Movements consist of active and passive movements. A restriction of movement might indicate a pathology or might indicate spasm. Okay, so we ask the patient to bend forward. That's testing for lumbar flexion. The lumbar flexion starts with reversing of the lordosis in the lumbar region. Okay, when you ask the patient to touch the ground with straight leg, we are testing both hip mobility and lumbar flexion. Okay, So any problem in this test might indicate hip pathology or lumbar pathology. This test can be done by Schober test. We later on talks about Schober test. Again, the reverse of lumbar flexion is lumbar extension, which is normally between 20 to 30 degrees. It's painful with facet joint problem. It's also be painful with the posterior disc pathology or closing of the foramen of the nerve roots. You have to test for the lumbar lateral extension, like this movement is normally 20 degrees on that side and it's 20 degrees on the other side. If it's painful, might indicate ipsilateral facet joint pathology or lateral disc protrusion. Lumbar rotation, actually, the rotation in the spine, 90% of it occurs in the thoracic region. So the rotation of the spine is mainly in the testing the thoracic region. So we fix the pelvis and the hip, and we ask the patient to rotate to both sides. One important part of the examination in the spine problem is neurological examination. Okay, so I tell you how we do. This is upper limb dermatome. You know, the top anterior part of the shoulder is C4. The lateral border of the bicep is C5. Lateral border of the forearm is C6. Thumb is C6. Middle finger C7, little finger is C8, and the middle border of the forearm is T1, middle border of the arm is T2. This is dermatome. It's very important, upper limb dermatome. We have lower limb dermatomes as well. In the inguinal region is L1, in the pocket area is L2, anterior of the knee is L3, lateral or medial border of the leg is L4, lateral border of the leg is L5, sole is S1, and posterior part of the neck of the knee is S2, and the gluteal region is S3, 4, 5. This is dermatome of the lower limb. We have also myotomes. Myotomes is also important. You have to know for shoulder abduction is C5, which is by axillary nerve or deltoid and deltoid muscle. Elbow flexion is C5, C6. Elbow extension is C7. Wrist extension C7. Wrist flexion C8. Finger extension C7 and finger flexion C8. Finger abduction is T1. This again for the lower limb myotomes. You have to know which nerve is responsible for which movement in both upper and lower limbs. Again, for the reflexes, it's critical to know. We have the ankle reflex is S1 and S2. Knee reflex is L3, L4. Biceps reflex is C5, C6. Triceps reflex is C7, C8. So this table actually tells you about the pathology. Where is the site of the problem? For instance, if the patient has a pain in dorsum of the foot, plus extensor weakness of big toe and foot, you may think there's a problem in L4, L5. Another example, if the patient has pain in the anterolateral thigh with weakened quadriceps, diminished patellar reflex, this might indicate L2, L3 pathology. Also, this table, please, is very important. You must read it very well. We have special tests after neurological examination. We have special tests for the back, sciatic and femoral nerve tension tests. The principles of this tension test is stretching the dural nerve root to produce leg pain. Positive will produce the patient's radicular symptom. Whenever there's traction on the nerve, there will be pain in the nerve, radicular pain. We have sciatic nerve stretch. We call it straight leg raise test. We can do it by two ways, Lasix test and slump test, okay? This is for the sciatic nerve. We have for the femoral nerve as well. The femoral nerve, actually for the sciatic nerve, you examine the patient on the spine. But for the femoral nerve test, you have to examine the patient on the prone position. Another test is one-legged hyperextension, Fitch test. As we said, lumbar hyperextension causes posterior element pain, like problems in the pars interarticularis. So whenever there's pain, you might indicate partial interarticularis problem. The fish test actually is a one leg hyperextension test plus a rotation component. This is more sensitive test. We call it fish test. Gillet test of sacroiliac joint. Maybe later on I'll tell you, I'll send you a video for that. Okay, maybe we explain by video. Schrober test also I will send it by video to you. And now acute spinal injury, history and examination. Okay, the first thing you have to, when there's in the field, when there's spinal injury or you think that spinal injury has happened, it's very important to protect the airway. Airway is a priority, especially in any unconscious patient. And again, you have to take care of the cervical spine. So whenever you want to open the airway in cervical spine suspected cases, you have to do the jaw thrust, not head tilt chin lift maneuver. So we have two maneuvers for opening airway in unconscious patient, either jaw thrust or head tilt chin lift. No, we do jaw thrust in these cases. So when to immobilize? Whenever you think about you think that there's spinal injury, as in case of pain in spine secondary to high velocity injury, any neurological signs or any severe spinal problems or pains, okay? Transportation should be done on spinal boards. In general, equipment such as helmets should only be removed by those trained to do so. The cervical spine will need assessment by cervical spine X-ray and CT scan of the entire neck. This should be done in the hospital or in the emergency department. So injuries could be muscular strain, ligamentous sprain, contusions, fractures, whatever. So maybe strain, sprain, contusion, fracture, or fracture and dislocation. So it depends on the kind of injury. Disc injuries, disc herniations, actually mostly occur in lumbar region. It's rarely occurs in the thoracic region or disc herniation. Okay. How do you do management of the musculoskeletal injuries of the back? It's easy. For the sprain and strains of the back are common. They do not require radiological evaluations. Only cold therapy should be used, and muscle spasm can be controlled by painkillers. Rehabilitation later on is important to restore normal muscle strength and firing patterns. Tight muscles like hamstring and hip flexors may be needed to stretch to prevent recurrence of musculoskeletal injuries like sprains and strains. This disease is a continuum of degeneration to herniation. In these degenerations, the disc will be very dry, so it might tear and cause local pain. History of this disease often precedes by activity and may precede activity, but may be aggravated by activity as well. Investigations for minor disc injuries or disc disease, we do not need any investigation. However, plain X-ray may show loss of disc height in advanced cases, and there may be associated farther joint arthrosis or osteoarthritis. MRI may be important to show loss of disc water content, small disc bulges, and annular tear. Treatment for disc diseases like adequate analgesia, ice, heat, rehabilitations, and again address hamstring and hip flexor tightness. The disc herniations mostly occur in L5, between L4, L5, and L5, S1. Okay, may cause leg pain, numbness, and weakness. Cervical disc herniations occurs most often in the lower cervical spine. Is a cause of neck pain or arm or head pain. Numbness and weakness may occur. Thoracic disc herniation, as we said, is rare, but may be a cause of chest or abdominal pain. Treatments, again, analgesia, bed rest. Okay, generally encourage activity as soon as the patients can cope with it. Back extension exercises may be helpful. Epidural injections may help with pain control, but do not improve neurological symptoms. Rehabilitation, again, is very important. Programs must improve significantly with conservative management over 6 weeks. Persistent radiculopathy. What does that mean? pain below knee or into anterior thigh for upper lumbar herniations, might consider surgical intervention, although studies suggest that long-term results are no better than with continued conservative management. The last thing we talk about Kodakwana syndrome. Our Agatha, when Kodakwana syndrome is very important. It occurs with central disc herniation. Might cause bilateral leg pain, subtle anesthesia, fecal incontinence, urinary retentions. Okay. On examination, you have loss of perianal and scrotal sensations, loss of anal sphincter tone. Require early surgical intervention. Okay. Because if it's not treated within 24 to 48 hours, it might end the patient permanently disabled. Zor spas, bohumilek, kati wai kati khosh. نشده چی باش با هولک زور سپاس